We are going to start with talking about some transmission of impulses and the central nervous system and the peripheral nervous system. So the nervous system is made up of the brain and spinal cord, whereas the peripheral nervous system is the relay between the brain and our organs, our arms and legs, muscles, and even our blood vessels. So the two together work well to keep our body functioning appropriately and smoothly. So you may or may not remember synapses from before, but a synapse is simply the way we transfer that electrical activity from one cell to another. So it could be nerve to nerve or it could be nerve to muscle in the synapse. And the synapse is actually where your neurotransmitter receptors are located. So they reach their receptor sites at the synapse. Okay, so the brain monitors and regulates movements and secretions, our ability to think, make decisions, and this is also where our information is received about the overall condition of our body. Okay, our brain interprets this information and then basically tells us how to react or how to respond. Okay, so what you see, how you feel, how, is it soft? Is it scratchy? When we taste something, is it sweet? Is it salty? Okay, so just that overall awareness, everything is processed here, and then it decides how we respond. Okay, so I think your book talks about how the brain is actually our field of vision. Okay, that's how we see is with our brain by the transfer of what our eye actually sees through light and all of that. The brain processes it, and that's how we see. So we see with our brain, not our eyes. Okay, so now there's a number of problems that can affect the central nervous system and how the brain functions. So primarily this chapter is going to talk about Parkinson's disease, Alzheimer's, seizures or epilepsy, and multiple sclerosis. So that's really the focus of this chapter. So we'll talk about how we're able to do the things we do as far as muscle activity and movements. So we've talked about the synapses, so now we're going to talk about the neurotransmitters. And so we have two different types. We have inhibitory and we have the excitatory, okay? So excitatory is going to be our acetylcholine, our epinephrine, and our norepinephrine. And then our inhibitory transmitters are going to be our dopamine, our serotonin, and our GABA neurotransmitters. So with all six of them, this is how we, remain kind of stable as far as our function of the body goes, okay? So when we start talking about these, think back to that autonomic nervous system and the difference, the sympathetic and your parasympathetic systems, okay? So as we move through, you may just want to take notes about the 6 different neurotransmitters, but you do need to know the difference in which ones are inhibitory and which ones are excitatory, okay? So acetylcholine is the first one we'll talk about. It's one of the most abundant neurotransmitters that we have in the central nervous system and the peripheral nervous system. So acetylcholine works on cholinergic neurons, okay? Maybe it doesn't make a whole lot of sense to you at this very moment, but as we move forward, we'll talk a little bit more about the cholinergics and anticholinergics. So acetylcholine plays an important role in memory and attention. Okay, so it is found in areas also that stimulates muscles to contract. Okay, so we're talking about when you blink your eyes, you move your arms, or for some of you, you erased your answers on your test because you thought you had it wrong. So without those neurotransmitters, without acetylcholine, you couldn't do any of those things. So any type of movement that you perform, acetylcholine is playing a part in that. Okay, so just for example, you need to move your right arm to scratch your nose. So there's a signal that's carried from, synapse to synapse or cell to cell, nerve to nerve by acetylcholine, which then triggers muscles to move that allow you to perform the act of scratching your nose. Okay, so if you think about it and how quickly these neurotransmitters work, They're like lightning speed. Okay, so then you have to also think about the opposite and how slowly a person might move if there's a disruption or a lack of acetylcholine in our bodies. Okay, so acetylcholine works in the parasympathetic system. It controls smooth muscle contraction, dilation of our blood vessels, certain body secretions, and it also slows our heart rate, because if we think about it and remember, our heart is one big muscle, and acetylcholine controls muscle movements. Now, we've all heard about epinephrine. Okay, it's adrenaline. It's a neurotransmitter that's produced in the adrenal gland, and it works in the sympathetic system, or those adrenergic receptors. Now, remember, when we think back to the autonomic nervous system, our sympathetic system is our fight or flight system. Okay, that's when epi comes into play. So fear and anger, those types of emotions, causes the release of epinephrine in the bloodstream, which then increases your heart rate, your muscle strength. And so if you think about, if you've been startled, if you're out late at night and you're terrified and you hear something and you want to run away, you can run that marathon, whether you really feel like you can or not. On a regular day at that point in time, you can run a marathon because of that epinephrine that's been released. So epinephrine also increases the contractility of the heart, or in other words, how hard that muscle squeezes to pump that blood through our cardiovascular system. Okay, so that contractility. Now let's talk about norepi, okay, or norepinephrine. It's very similar to epinephrine, sorry about that, as far as their chemical structure. Now, they're structured the same, but they work differently. Okay, so epinephrine works on both alpha and beta receptors, whereas norepinephrine only works on alpha receptors. So alpha receptors are found in arteries, and beta receptors are found in the heart, lungs, arteries, and skeletal muscle. So that's how they're different as far as epi and norepi. Okay, it's where they work in those receptors. Now, most of you who work in healthcare, you've probably heard about the use of epi, or maybe even out in the real world, for those of you who don't work in healthcare currently. So epinephrine is mostly or most frequently used during a code situation. Okay, we want to get that heart rate up, get that heart pumping again. So that's like our first line of defense to get that heart rate back up. That's our adrenaline. So then you may have heard of an EpiPen. Okay, that's epinephrine also, which we use in the treatment for anaphylaxis, those severe allergic reactions that can cause swelling and then in turn cut off your airway, basically. Okay, so that's your excitatory neurotransmitters. Okay, so just kind of think about what they do and where they work. And we're going to move into the inhibitory neurotransmitters. So we're going to move on to the inhibitory in this slide. This is our dopamine, our serotonin, and our GABA receptors. Okay, so we've talked a little bit about dopamine. It's a neurotransmitter that is actually made by changing an amino acid called tyrosine into a substance called dopa. And then it's transformed into dopamine. So tyrosine is really the building blocks of protein. So I say all of that so that you understand when we get to talking about levodopa, carbidopa for Parkinson's disease, you'll understand the relationship in dopa and dopamine. Okay, and that's how you get to dopamine. So dopamine affects a lot of behavior and physical functions, and so it affects our learning, our motivation, our heart rate, sleep, mood, and our attention span. So as we move forward in this particular unit, you're going to find that most mental health issues are related to dopamine, either too little or too much of it. Okay, so Serotonin we've talked about just a little bit. Many times serotonin, if you remember, is made from an amino acid called tryptophan. If you listened to the lecture previously, when we talked about why you're feeling so sleepy about or after Thanksgiving dinner, that's because turkey has a high amount of tryptophan in it, and then tryptophan is then turned into serotonin. So serotonin, remember we talked about being in our digestive system. It is also in our central nervous system. So serotonin impacts our emotions, our motor skills, and this particular neurotransmitter actually aids in digestion, sleeping, our mood, and remember we talked a little bit about those serotonin receptors and nausea. Okay, so as long as our serotonin levels are normal, we're happy and we can stay focused, and normally we're emotionally stable for the most part. Okay, yes, I understand nursing school can make us all crazy, but for the most part, we should be stable if our serotonin and dopamine levels are within a normal limit. Okay, so if you have a disruption in the serotonin, what you would see in the patient is maybe increased depression, anxiety, some sleeplessness, or even, episodes of insomnia or periods of insomnia. So then we have the GABA neurotransmitter. So the GABA neurotransmitter is considered the regulatory neurotransmitter. Okay, it basically controls overexcitation of nerve impulses. Okay, so smooth muscle requires both excitatory and inhibitory neurotransmitters to give us that smooth functioning ability. Okay, so I think the book talks about an example that's based on the strength of your arm in throwing a baseball or softball versus rubbing your eye. Okay, if we rubbed our eye with the same force or strength that it takes to throw a softball or baseball, 60, 70 miles per hour, can you imagine the damage you're going to do to your eye? So that's where GABA comes into play. It regulates the two neurotransmitters to give you that exact amount of movement that you need. Okay, so without that balance, there would be lots of jerky, fast movements and maybe too much of a movement, okay, or too much strength. So this is where we get to the point when we talk about overexcitation, okay? So this is where if they have an imbalance, this is where you're going to start to see the symptoms of Parkinson's disease, Alzheimer's, and then our seizure activity. So we'll talk about all of those. Remember, this chapter focuses on those particular diagnoses. So with both of them, the inhibitory and the excitatory, as long as they're within normal limits, we have a good balance in our body to maintain that stable function. We have a level mood for the most part, and we are able to sleep pretty well. And then our movements are, again, that smooth movements that we experience. Okay, so we'll move on to talking about dopamine, I think, or I'm sorry, Parkinson's disease, which is one of the first ones that we talk about. So let's talk about Parkinson's disease. So with Parkinson's disease, it is simply a disorder in which your patient does not have enough dopamine to send the appropriate signals to muscles to move correctly. So Parkinson's disease is a progressive brain disease and it is not reversible. Okay, so typically by the time your patient has a diagnosis of Parkinson's disease, it's pretty well progressed. So you can't reverse the damage or the loss of function that is already there, but we can control the progress going forward and control some of the side effects or symptoms of Parkinson's disease. So remember, dopamine is an inhibitory neurotransmitter, and if there's a disruption in dopamine, then you're going to start to see some movements that are going to be really rigid and jerky and almost robot-like in a sense. But in Parkinson's disease, it talks about cogwheel rigidity, and we'll talk about that in the next slide when we talk about hallmarks of Parkinson's disease. So you'll see that cogwheel rigidity, and we'll talk a little bit more about what that is. But just those movements become jerky and robot-like. So with a lack of dopamine, it basically allows your muscles or those impulses, the synapses, to receive and also respond to too much stimulation. And that's what creates the excessive movements that we're going to talk about. So remember, dopamine is inhibitory, and so it's going to slow excitement at those synapses or those neuron activities. Okay, so if we get our dopamine levels to a normal sense, then it can control those extra movements and make them less rigid. Okay, so we're going to talk about those in just a minute. But just remember that dopamine is inhibitory. Okay, so remember you have to know the difference between inhibitory and excitatory. This slide is here basically to just give you a visual of an impairment of someone in or with a diagnosis of Parkinson's disease. So you'll see in that healthy neuron or that synapse, you'll see all the little receptors at the bottom, and then you'll see all of the dopamine that's floating about. So with someone who has a decrease in dopamine, they still have all of the dopamine receptors. It's just their brain is not producing enough dopamine in order to create those normal, healthy, movements. And so that's when we come into the movement disorders that you're going to see in Parkinson's disease. So our dopamine agonist that we're going to talk about is going to be your carbidopa-levodopa, your pramipexole, ropinirole, and rotigotine. So those are your agonists that we're going to talk about. Now, these medications, again, do not reverse or stop Parkinson's disease. It simply um, gives them some relief from those side effects or the symptoms of Parkinson's disease, the muscle rigidity and those tremors and some of those bradykinesia, that slow moving, slow motion type movements and those types of things. So it just kind of gives them some relief and it allows them to maybe still participate in some of their, activities of daily living that we always talk about. Um, give them some semblance of a normal um, daily life for some time, for as long as we can continue giving them the medication. So the most effective one is going to be your carbidopa-levodopa. Now, this one is specific in that the effect of this one particularly diminishes at about 5 years. Okay, so after 5 years, we're going to have to come up with something else as far as treatment, but it is the most effective until about 5 years. Our body kind of develops a tolerance to it, is what I guess I should say. Much like pain medications, it develops that tolerance. So with this particular drug category, there is a weaning off, just like a pain medication. When you start to feel that pain coming back, same thing with dopamine agonists. They're going to start to see those symptoms return when that medication starts to wear off. So the closer to their dosing time, you're going to start to see that shuffling gait reappear. You're going to start to see some of those rigid movements again, okay, maybe some expressionless, discussions or something of that nature. So you'll have that weaning off period, and that is just near dosing times, okay? So now the therapeutic effect of a dopamine agonist can take up to a couple of months even to see those effects and those symptoms resolved a little bit, or alleviated, I should say. So these are typically used by themselves in early Parkinson's disease. It can be used in conjunction with another medication later in Parkinson's disease. But the goal of a dopamine agonist is to increase those dopamine levels at the synapse in the brain so that your patient is better able to function. Now, there is a YouTube video link on this particular slide if you want to take time to watch it. It's about 3 minutes long, and it talks about some of those shuffling gaits and one patient who, a couple of them have been diagnosed. And one of them, I think his name is David or Dave. Anyway, he has that mask-like appearance when he's talking. So you can kind of get a feel for that. And then one of the other people in this one actually has Parkinson's disease. And she talks about her muscles and how rigid they are. So if you'll just take about 3 minutes and watch that video, they also talk about the wearing off of these medication also and returning of the symptoms. So if you have 3 minutes, just take that time and watch it. So lastly, your dopamine agonists. Again, our agonists are just exactly, or doing just exactly what a normal dopamine in the body would do. Okay, so it's doing the same thing that we would normally have going on in the body. Okay, remember, agonist versus antagonist. Don't forget that. Almost every patient who has a diagnosis of Parkinson's disease will eventually require levodopa. Now, levodopa is then converted in the brain to dopamine. So why do we have this carbidopa-levodopa combination? Well, carbidopa enhances levodopa so that lower doses can be used. Levodopa, like I said, is converted into dopamine in the brain. So by carbidopa enhancing the action of levodopa, we're able to use lower doses because many patients who take levodopa complain of nausea and vomiting. So if we can use a lower dose, then that's what we would want to do for our patient, right? So there's carbidopa. Let me just explain this part. Carbidopa prevents the breakdown of levodopa in the blood, so in the cardiovascular system. It prevents that breakdown. Now, levodopa can actually cross the blood-brain barrier, which carbidopa cannot. I know this is confusing, but just play this back and take notes and look at it over and over until you know the difference. Okay, so remember, levodopa is the one that can cross the blood-brain barrier. So by doing that, we have levodopa available and more of it, which can be transferred into dopamine once it reaches the brain. Okay, so it's converted into dopamine, which in turn makes more dopamine available at those receptor sites for your patient, giving them a greater relief of symptoms. Okay, now levodopa is typically always used in a combination because it has a very short half-life. Okay, now it peaks in about an hour, but it wears off in 4 to 5. Okay, so that's why we use this combination drug. So we turn off that mood swings or that worsening of symptoms that you start to see by using this combination. Okay, it lasts longer and we don't see that swing from, severe mood swings, I guess I should say. Now, we do need to monitor liver function. We'll talk a little bit more about this in teaching and things, but we want to monitor liver function because this particular medication is metabolized in the liver. And so with me saying that, that should automatically lead you to thinking about what labs am I talking about when we talk about liver function. Okay, so first of all, you could do your amylase, your lipase, liver function testing, which includes all of those things, but also monitoring that blood count. Okay, this can also cause GI bleeding. Okay, and we'll talk about that too. So remember your liver function testing, and then also your complete blood count, because if it's irritating to the GI tract and it can cause bleeding, then we want to monitor for that blood count. Okay, your red blood count, your white blood cell, red blood cells, that type of count that it will give you on that CBC. Now with carbidopa-levodopa, this particular group, you have to avoid protein-rich foods when you are giving this medication. So in order to prevent that GI upset, you want to give it either with typically a light snack, but we want to make sure that it's something that is lower in protein, because what happens is it competes in that intestinal tract and it decreases the absorption of carbidopa-levodopa. Okay, so just remember, anytime you give a patient carbidopa-levodopa, you always want to give it with a low protein snack. Okay, and also remember when we talk about, of course, the extended release that is available for this medication, that your patient takes that whole. Okay, remember, we do not crush, and we do not, we don't want them to chew it either. So just make sure and remind them to take that whole. We don't ever want to crush it. Ropinirole or Requip, which is a dopamine agonist, is one that is typically used for restless leg syndrome specifically. So by, of course, making more dopamine available, stimulating, those receptor sites, we're able to decrease that crazy movement and that uncontrollable movements of your patient. Okay, if you've ever seen anyone with restless leg syndrome, it is probably one of the most, I hate to say horrifying, but one of the most horrifying things I think that a person could be suffering from. Because if you've ever seen one even medicated and trying to sleep, it's crazy to see their legs are just flying up in the air and moving about. They have no control over that. So you can imagine how tiresome that could be. Now, if we have a patient with restless leg syndrome and they are taking ropinirole, we want to make sure we educate them on drowsiness. Remember, dopamine affects our mood, and it is an inhibitory neurotransmitter. So if we're inhibiting that acetylcholine, of course, we're going to maybe see some signs of drowsiness and that type. So just be sure and educate them if they're taking ropinirole that they may experience some of that drowsiness and maybe a little sleepier than usual. Okay. One medication that you can use in Parkinson's disease to help decrease some of that muscle rigidity and those other symptoms is a medication called benztropine, which is an anticholinergic. Now, earlier in the slides, I talked about cholinergic and the parasympathetic system, that acetylcholine. So remember, acetylcholine is your excitatory neurotransmitter. So by inhibiting that, if we can't increase the dopamine, we can decrease the excitatory to try and balance those out. So it basically blocks that acetylcholine. Now, this particular medication should be avoided in patients who have glaucoma, and this really goes for any anticholinergic because sometimes those anticholinergics can cause, I think it's narrow angle glaucoma. So we don't want to induce something on a patient that they aren't suffering from. But if they do have any type of glaucoma already diagnosed, we don't want to make that worse, okay? Because it does tend to increase that ocular pressure. And that's really what glaucoma is increased ocular pressure. So we don't want to increase it even more because it can cause severe issues with blindness or any other type of issue as far as the eye goes and that visual impairment. So we don't want to do that. So just remember, anticholinergics can also be used in the treatment of Parkinson's disease. And the way that works is blocking that acetylcholine to balance out those neurotransmitters, the excitatory and the inhibitory. Some of the side effects with our levodopa, carbidopa, and our dopamine agonists are postural hypotension, headache, GI disturbances, some insomnia, and confusion. So postural hypotension comes into play because remember, dopamine is an inhibitory neurotransmitter. So we're increasing our inhibitory response, therefore decreasing that excitatory response. So you're going to start to see some lower blood pressures. So what do we want to monitor? We want to monitor vital signs, blood pressure, of course, and we want to make sure that with postural hypotension, we're educating our patient about changing positions slowly, okay, reducing that risk of falls. If they're going from a sitting to a standing position, just do it slowly. Headache, again, is just the same thing as postural hypotension. We're increasing that inhibitory and decreasing that excitatory. So you may see some effects from that vasoconstriction with those neurotransmitters. Now, the GI disturbances, again, remember, it can cause some nausea and vomiting if we do the levodopa carbidopa. So the levodopa is really what causes the GI disturbances. So by giving the carbidopa with it, we can decrease the amount of the levodopa that we give. So, GI disturbances. I know it's best absorbed on an empty stomach. Your book tells you that. Some people, in order to alleviate some of those disturbances, will take it with some type of snack. But remember, we want to make sure that we're reminding them to do it with low or no protein snacks because protein delays the absorption of this medication. So when we do that, then your patient's therapeutic effect of this dopamine agonist is reduced. Therefore, your patient may suffer from one of those on-off episodes on more occasions than you would like to see. Okay, so those GI disturbances can be reduced by no protein or extremely low protein snacks. Insomnia and confusion, again, we are talking about dopamine, and dopamine affects our sleep and our mood. So you may start to see some of those insomnia cases and confusion. So some of the adverse effects or adverse reactions to our dopamine agonists are our dyskinesias. Remember, that's just that uncoordinated movement that is uncontrollable by the patient. Okay, so if you watch the video, it talks about she's sitting at dinner with her husband, I think it is, and his arms just flying about uncontrollably. So imagine how disruptive that can be to a family, you know, in their social life. Dystonia, of course, is just that loss of muscle tone. Now, I will say that we need to encourage our patient and their families to report any type of involuntary movements like chewing gum or the appearance of chewing gum when they don't have anything in their mouth, or grinding of their teeth. Your book talks about grinding of your teeth. A lot of time, many times you will see patients who have a particular diagnosis of Parkinson's have what they call tongue rolling or pill rolling. They'll roll like a little pill between their fingers, or that's just the tremorous movements that they have that are repetitive involuntary movement. It looks like pill rolling between their fingers, or they keep protruding that tongue, rolling it around. Okay, so those are some things that can also indicate dystonia. So make sure that you educate them about what to report. Now, as far as delirium, psychosis, and hallucinations, that goes back to the nightmares, the paranoia, and those types of things. So we want those reported. Impulse control can be, again, gambling, excessive shopping, binge eating, or even a hypersexuality can, you know, be included in that impulse control. So we want to make sure that patients and families alike are educated on the adverse reactions. Now, with dystonia, the thing about those types of movements are, one, we need to seriously assess them because it can either be an adverse reaction, or in some cases, it could just indicate a progression, a further progression of this diagnosis, okay? Because as the disease progresses, you're going to start to see more and more of that dystonia. So just be mindful of those. So our responsibility as a nurse in educating this patient is, number one, that this comes in several forms. There are tablets and extended release tablets. So remember, if they're extended release, we don't want that whole entire dose being released at once. So we don't want to crush, chew, or half that tablet unless it's scored. If it's a scored tablet, then it can be halved. But just try and remember to remind your patients not to crush or chew that medication. We want to give it with 6 to 8 ounces of water, and we want to do that 30 minutes prior to a meal. Because remember, most of the time when we're eating a meal, we're going to have some type of protein. So we want to avoid those high protein meals because remember, it decreases the absorption. Therefore, we're back to that on-off session of alleviating the side effects. So avoiding protein, low protein snack, or no protein at all. Changing positions slowly, that goes back to that postural hypotension, and we talked about why we would experience that. Again, monitoring for that cardiac hypotension and some dysrhythmias. Report any behavioral changes. This is going to be your hallucinations, your psychosis, or delusions. Remember that paranoia, nightmares, things like that. And monitoring for dyskinesia and dystonia. If those are severe, then we might need a change, a dose change for that patient, okay? Especially, we're going back to the older patients. Remember, everything is a little slower, so we may need a dose change because it's just hanging out in there. It's not moving through as quickly, so lingering may need a dose change. So one form for our dopamine agonist is a transdermal patch. So we always want to make sure they're rotating that side. Don't use the same site for, I think your book says, 14 days. So with this particular patient, you might want to think about placing them on the back side, somewhere on the back that they can't reach, especially if they're in a facility, because remember their cognition is also at risk and has lessened that time. So put it on the back so that they're not just taking it off and not really thinking about it, especially as the disease progresses, and they become worse as far as their cognition. Now, I want to go back to the cardiac changes. So the cardiac changes or dysrhythmias that we want them to watch for is due to that beta stimulation. Remember earlier we talked about epinephrine and how it is present in both alpha and beta cells. Okay, so remember, if we have epinephrine that's stimulating that system and we have dopamine that's trying to level it out, then we may have a little bit of uncoordinated or discoordination, I guess is the correct word, that might cause some dysrhythmias in our cardiac system until we get those leveled out. Remember, we have that excitatory and we have that inhibitory. So we want to make sure we're monitoring for those. So any palpitations, anything like that, we would want our patient to be aware of and report those immediately if they were to experience that. So we have talked about some safety aspects, some psychosocial things, and their digestion and nutrition. So as far as safety goes, we want to make sure that if they need some type of assistive device, a walker or wheelchair or something, that we have that available to them at our facility, or just making sure they have those available at home even if necessary. We again encourage them to change positions slowly, and we talked about why. Now, a couple of things that we typically see on testing or even ATI is safety when it comes to them being a fall risk. Okay, that's going to be mindful as pets that are, of course, circling your feet as you're trying to walk, because they have that shuffling gait where they're not picking up their feet to walk. So it creates a safety issue there. Throw rugs that you would have in the kitchen, living room, front door, whatever. Those can potentially be hazardous for our patients if they are, again, at that on-off point where they're experiencing that shuffling gait, and it creates another risk, and it increases their risk for falls. Okay, so while we're talking about falls and their shuffling gait, in the hospital, we're trained to always have those rubber socks on our patients, or the socks with the rubber on the bottom, the safety socks, the non-skid, I guess they call them. So with this particular patient, is it a good idea to put those rubber-soled shoes or those rubber-soled socks on that patient if they are in fact walking with that shuffling gait, that stupor? So think about how that would create an increased risk of falls. If they're shuffling and they have these rubber soles, that would increase their risk more so than just having a smooth sole on the bottom of their shoe. Okay, so rubber soles are not quite encouraged in instances of patients with Parkinson's disease. Okay, and so then you also have to think about their balance. So stairs. Okay, we want to try and avoid taking them up and down stairs because they do have that imbalance going on. Now, as far as psychosocial, we talked about when we use the dopamine agonist that they're better able to participate in their activities of daily living. So feeding themselves. Of course, for Parkinson's, they do have those tremors, those slight tremors. So they do have special silverware that's weighted for them to use. So they, I don't know exactly how they work, but I don't know what makes them heavy, if it's the metal or they have weights inside them, I'm not sure. But they have special silverware that they can use in order to continue feeding themselves, at least until the point where they just absolutely can no longer do it. So just altering some of those things. Clothing, think about that. If you have those tremors of how hard it would be for a patient to button a shirt or even zip that shirt or jacket or their pants even. So think about some things that you could encourage families to bring if they're in a facility. Shoes with Velcro, okay, or a slip-on shirt, just a t-shirt or something, so that they don't have to button or zip. So they're still they still have that little bit of independence, okay, and they're not actually having to ask for help all the time or feeling hopeless or depressed because they have lost a little bit of that independence. So support groups for the family or even themselves, okay, in the very early stages, they are isolated because if you think about that patient, if you watch the video, one of the ladies talked about being in a restaurant and her husband, I think it was, with just those movements, uncontrollable movements, and where his arms would just fly up in a restaurant or things like that. So that can truly isolate a family when especially in today's society, how we tend to maybe stare at other people. So just decreasing that social isolation of those families and those patients. It also can help decrease the stress and decrease those symptoms of Parkinson's if we can continue keeping that family together, supporting them as much as possible. Now, when we talk about digestion and nutrition, we want to talk about, because, everything tends to slow down for them and become a little bit harder to do, and it's a slower motion. So we want to think about some softer foods for them, something that's easier to chew. We also want to maybe increase their fiber due to that decrease in that GI motility. Okay, stool softeners. Maybe they're not up and walking about as much as they were. So we want to think about constipation. And then again, monitoring those snacks and foods for protein content. So we want to make sure that we're decreasing their protein-rich foods, okay, especially with medication administration. So those are just some of the nursing interventions that I can personally think of that we should assist with, educate on, and support families with, okay? Some drug interactions with the use of dopamine agonists are going to be our antihypertensives. So if we are already at risk for hypotension with the use of a dopamine agonist, then we may need a dose adjustment on any antihypertensive that your patient is taking. We don't want to bottom out their blood pressure. So if we're already taking an antihypertensive on top of now a new prescription for a dopamine agonist, we really have to think about dose adjustments for this particular combination because we don't want them, bottoming out. So another interaction is with an MAOI or monoamine oxidase inhibitor. MAOIs are typically your antidepressants, and you'll usually see those in most psych patients as far as medications for MAOIs. Now, what an MAOI is monoamine oxidase, and monoamine oxidase actually breaks down neurotransmitters. So it breaks down epinephrine, serotonin, norepi, and your dopamines. Okay, so what you have to think about with your monoamine oxidase inhibitors is that monoamine would typically break down dopamine, serotonin, and those other things. But in this case, we're using an inhibitor. So that stops the monoamine oxidase from breaking down those neurotransmitters. So if you recall from last testing unit, we talked about serotonin syndrome. So if you think about using an MAOI with a dopamine and agonist, then you're going to have all of those excessive neurotransmitters floating around. So you have too much serotonin, too much dopamine, or not really too much dopamine because that's good for your patient, but too much serotonin can cause serotonin syndrome. And remember, that's when they have the high fever, the sweating, the confusion, tremors, agitation, that rapid heart rate. So remember serotonin syndrome. If you don't remember all that, then go back and revisit that. Okay, so that's why an MAOI would be considered a drug interaction with this particular category. Phentoin just simply reduces the effectiveness of dopamine. And multivitamins that have iron, of course, decrease the effects of carbidopa-levodopa. Okay, so vitamin B6 increases the metabolism of levodopa, especially if it's given by itself. So if we increase our metabolism of levodopa, then we leave our patients subject to that on-off symptom relief, okay? So they're not getting as much coverage for that relief of symptoms if we are increasing the metabolism of that dopamine agonist. Now, if you recall Reglan from the last chapter, that's your metoclopramide, this particular medication reduces the effectiveness of a dopamine agonist because if you remember, Reglan is a dopamine antagonist. So basically, we're just canceling out the use of the medication, okay? Now, we want to avoid using dopamine agonists with sedatives like your Valium, any type of sedative, any type of like benzodiazepine or something like that, because we already have some sedation from our dopamine agonist, then we go ahead and give them a sedative, so therefore we're increasing that drowsiness. So we don't want them taking both of them together if we can avoid that. So one other point that I wanted to touch base with you on as far as drug interactions was a hypertensive crisis, because your book talks about the use of an MAOI and a dopamine agonist being a drug interaction. And so I wanted to explain that to you. So a hypertensive crisis is simply a severe or huge increase in extremely high blood pressure, which is like at stroke level. And so how that comes about is MAOIs are taken with the dopamine agonist to prevent the breakdown of dopamine. So monoamine oxidase actually breaks down another amino acid called tyramine. And so tyramine is an amino acid that regulates blood pressure. And it is found in some foods, typically your aged foods like aged meats or cheeses, pepperonis, certain foods like that. So what happens is when you use that MAOI, you're inhibiting the breakdown of tyramine. So then you have that propensity to have those extreme high blood pressures because it helps regulate blood pressure. So if you have an excess of tyramine floating around in there, then you're going to see those blood pressures increase. So you have to be really careful about using those. together. So hypertensive crisis, this is what your patient's going to experience if they are in a hypertensive crisis. It's going to be that severe chest pain, severe pounding headaches. And if you have a migraine, you're going to, I mean, if it is extreme, you're going to maybe have some confusion, blurred vision, and then they're going to be nauseous, they're going to be sick, they're going to have some major anxiety because they feel like their heart is about to explode. And it very well could be. I mean, it can lead to stroke, seizures, and unresponsiveness ultimately. So that's what it means when we're talking about a hypertensive crisis and what that can create given that combination of medication. So just be mindful of what that hypertensive crisis is and why that combination causes or has a risk of hypertensive crisis. So monoamine oxidase that we talked about, I wanted you to understand that there are two different types. There's MAOA and MAO-Bs. So they break down those neurotransmitters that include dopamine, serotonin, epinephrine in our central nervous system. Now, monoamine oxidase A is primarily in fibroblasts. So they degrade serotonin and norepinephrine, whereas our monoamine oxidase B, which you saw in the last one, is present in platelets in the brain. So that's the one that breaks down our tyramine. Now remember I talked about tyramine is the one that controls blood pressure, and that's where if we use an inhibitor, then we run into that hypertensive crisis. So I just wanted to put this in here so you could kind of see the difference in the monoamine oxidase A and monoamine oxidase B to kind of just maybe help you understand what it breaks down and why we run into that hypertensive crisis when we use a monoamine oxidase inhibitor, okay, or serotonin syndrome when we use a monoamine oxidase inhibitor. So previously I told you what tyramine was. I told you that it was an amino acid that helps regulate blood pressure. And by using those MAOIs, we inhibit the enzyme that breaks down tyramine. So by doing so, again, we're increasing that blood pressure because that tyramine is excessively floating around. Now, if you look on page 166 in the box 9.2, I will tell you there are some foods that you need to be aware of when discussing tyramine because you will see this on this test, I assure you 100%, because tyramine is important in blood pressure control, but you will see it in your medications for this chapter, and you will also see it again in your mental health chapter, okay? And I assure you, you will hear about this again in Miss Price's mental health class. So just be aware of some of the foods. A lot of it is just those cured or those aged foods like your smoked meats, your salami, pepperoni, and aged cheeses, okay? Avocados, bananas, figs, raisins. Most of the time when we're talking about testing, you're going to see the meats, the cheeses, the sauerkraut, and yogurt. Okay, so make sure that you know at least those few foods that contain tyramine, okay, because those are some of the things that you want your patients to avoid if they are taking an MAOI, to avoid that hypertensive crisis, okay? So you can see I've told you everything about the monoamine oxidase inhibitors here, and I talked about it previously. Okay, so what happens when you have too much? You have blood pressure issues. Okay, and what happens when you have extreme blood pressures? Then you're moving into that hypertensive crisis. Okay, so know what that tyramine is, know what it causes if there's too much of it, and that it regulates your blood pressure. So our COMT inhibitors and our MAO-B inhibitors are both anticholinergics. If you remember, I talked about anticholinergics previously, and that we're basically blocking the action of that acetylcholine at the receptor sites, or those synapses. So that way we're trying to rebalance our dopamine and our acetylcholine, which is our two neurotransmitters, our inhibitory and our excitatory. We want to bring back that balance. So the COMT inhibitors are going to be your capones, your CAPONEs, okay? So COMT is actually an enzyme that breaks down neurotransmitters. Now, it also breaks down our dopamine agonist drugs, okay? So by using the COMT inhibitors, it suppresses that enzyme from breaking down dopamine in our drugs so that they stay in the body a little bit longer and gives our patient a little more relief from their symptoms. Okay, so we're rebalancing again that acetylcholine and that dopamine relationship so that we function a little bit smoother. Okay, so we're just inhibiting the breakdown of that dopamine and restoring the balance. Our COMT inhibitors have a couple of expected side effects, which are minimal, but we need to make sure that we address them with our patients. So again, GI upset, we want to make sure that we educate them to take that with a meal just to prevent that. This particular group of medications can cause discoloration of the urine. It can turn brownish orange, okay, so make sure you educate them on that so that they're not just completely shocked or thinking that they have some type of maybe bleeding going on, okay? I mean, brownish orange versus red is, yeah, quite a difference in color, but your patients may freak out and they're going to call, and so it's better to know ahead of time, okay? And then liver functioning test is going to be done every 6 months, especially because tolcapone can be um, damaging to the liver. Okay, so they're both of these drugs, your COMT inhibitors, are metabolized in the liver, of course, but tolcapone has a high risk for causing liver failure. So we want to first test the function before starting, and then every 6 months while they're taking this particular medication. Tolcapone, I will say, is used only when every other available drug has been tried and failed. So with this particular group of medications, your COMT inhibitors and your monoamine oxidase B inhibitors, the significant adverse effect of this one is, of course, your dyskinesias. That's your extreme involuntary movements. The ones that look like those extrapyramidal symptoms. Okay, so we talked about those dyskinesias in a previous slide. So some of the other things are your delirium, psychosis, and hallucinations. Again, that goes back to your nightmares and the paranoia and those types. So those are the same with this group as it was with your dopamine agonist. Now, the one that is significant here is your malignant neuroleptic syndrome. Now, this will, it does sort of look like your serotonin syndrome, but it's a little bit different. So this one is going to have some severe agitation, unstable blood pressures, extremely high fevers, that muscle rigidity, and tremors. And if it is left untreated, it can actually put your patient into a coma. Okay, so it is severe. So we definitely want to monitor these patients anytime they're taking a COMT inhibitor or a monoamine oxidase B inhibitor. So make sure that you understand what you'll see in your patient with a malignant neuroleptic syndrome, because when you're testing, it may just give you a patient scenario that talks about agitation, muscle rigidity, tremors, coma, and give you some vital signs. And then you have to pick out whether it's serotonin syndrome or malignant neuroleptic syndrome or whatever. Okay, so know what that is. Now, the link that's in here is another little short video that kind of talks about dyskinesia and some of those involuntary movements and how debilitating those can be for your patients. Okay, so if you have a few minutes, just kind of watch that video. Some of these things really are helpful because it will lead you to the correct answer when you're testing. It will also lead you to be very sympathetic to some of your patients and then supportive of their families when we talk about educating them and providing them support and things of that nature. It will really, it's quite an eye-opening little video. So we're sort of familiar with monoamine oxidase and what it does. So there are two types, and I talked about A and B. So the MAO-B inhibitors that we use is your recycling. And this has to be given at the same time daily, okay? And again, this medication is specific for breaking down dopamine and serotonin, okay? So it's selective. So remember, when we're inhibiting certain things that relate to monoamine oxidase, again, we're going to go back to tyramine, which also controls blood pressure. So with the MAO-B inhibitors, we're going to monitor blood pressure. We're going to avoid those foods with tyramine and beverages, which is beer and those types of beverages, okay? So reporting those signs of hypertensive crisis, again, those severe headaches, palpitations, nausea and vomiting, go back and revisit that hypertensive crisis and what you'll see in your patient if you have forgotten. We want them to report any psychosis, any changes, in that mental status, okay? And then with this particular medication category, the MAOBs, they may actually be able to decrease this dose if they're adding levodopa-carbidopa, okay? So just know that with this particular drug, it has fewer side effects than the MAOIs, okay? But just know what to report, your signs and symptoms of hypertensive crisis, and that anytime we're talking about monoamine oxidase, we want to look at blood pressure and foods with tyramine. So we want to look at their diet. Alzheimer's disease or dementia is just that progressive loss of brain function. Now, our brain typically shrinks to some degree as we age, but in Alzheimer's disease, it's different. It's not just a shrinkage due to age. People who have a diagnosis of Alzheimer's sometimes can have just a predisposition genetically to develop Alzheimer's. Now, what happens in Alzheimer's is there's a buildup of protein that basically entangles throughout the brain, and it basically stops neurons from functioning. They lose connections with other neurons and they just die off. So just like with Parkinson's, there's not one true test to say, yes, you have Alzheimer's. So it's really just interviews with families, things that you're seeing in that patient, the loss of memory, they forget how to get home. That is typically how most people begin to suspect Alzheimer's or actually get a diagnosis of Alzheimer's is you hear so many times of families who have said, oh, we found out after, mom or dad was sitting in the middle of the road and the police officer called to say, hey, your parent doesn't know how to get home. That's typically one of the first signs, is their cognition, their memory is impaired. So what happens when those neurons die off is our acetylcholine is decreased. So acetylcholine it plays a huge part in our memory, and so that's where we get into trouble with remembering things. These patients also have lots of mood changes. Their judgment is not what it used to be. Okay, they have poor judgment, and personalities tend to change. Now, if you've ever been around someone who suffers from Alzheimer's or dementia, it can be very heartbreaking and very straining on a family because of those changes. Not only are they taking care of someone who can't recall certain things or do certain things for themselves anymore, maybe even as simple as brushing their teeth. They forget how. So it's very stressful. Their personality changes. They may have been the sweetest little church-going lady ever, and then Alzheimer's sets in, and they're like the devil himself has stepped in and taken over. It's so heartbreaking, but families struggle with that. So there's a set of physical, I guess, or 10 warning signs of Alzheimer's disease on page 167. So if you will just kind of look at those, it talks about memory loss that disrupts daily life. So things that they've known how to do for 50, 60, 70 years, they just suddenly or over time forget how to do them. Challenges in problem solving, okay, their judgment's impaired, decreased or poor judgment. Difficulty again with those familiar tasks, either at work or at home, confusion to time and place, those types of things. Some patients even have difficulties talking and writing. Okay, so how are we going to treat Alzheimer's? Well, we use a cholinesterase inhibitor, which helps maintain that level of acetylcholine at those synapses. Okay, so by increasing that acetylcholine, then those neurons still function a little bit more than what they would have without this particular inhibitor. So our cholinesterase inhibitors are going to be your donepezil, your rivastigmine, and your galantamine. Okay, so be familiar with those. I know that they're going to test you on those, so be familiar with those three specifically. They're on page 168. Okay, so basically what they're doing is preventing that breakdown of ACH, or acetylcholine, so that there's more available at the synapses to create that nerve-to-nerve transmission, so that we can maintain some of that process that they lose, their ability to think, talk, remember how to do things. Okay, it's not reversible, but we can at least maybe preserve what we have, just like in Parkinson's. I think we've already talked about most of these, but just as a review, there is no single test to determine Alzheimer's disease. We've talked about the things that you would see in your patient, the loss of memory, not knowing how to get home, things like that. Just some things that can be mistaken for normal aging. Okay, maybe a little loss of brain function, but not to the point that you would forget how to brush your teeth or how to get home or things like that. Confusion to place, time, and again, how to get home. Changes in mood, judgment, and personality. And then again, those factors in Alzheimer's disease are on page 167. And we talked about those. That's your 10 warning signs. And then risk factors, of course, as I said, sometimes a family predisposition, okay, having that specific gene for Alzheimer's disease. Just because you have the gene doesn't mean you're going to get it, but you have a higher risk for it. And then, of course, older than 65. So how are we going to treat it? So we can't reverse Alzheimer's disease. We can maybe slow the progression just a bit with medication, but the two main categories are going to be your cholinesterase inhibitors and your NMDA blockers. Okay, so we'll talk about those. They're on page 168. 9.2 is the table. So cholinesterase inhibitors is, of course, you see the stem choline, which is part of acetylcholine. So it is an enzyme that basically destroys acetylcholine. Okay, that's your ASC, your cholinesterase. So if we're inhibiting that cholinesterase, then we have more acetylcholine available at those synapses, the firing of those electrical impulses to send messages out. So this helps delay that memory loss and improve their abilities for just a little while. So cholinesterase inhibitors are only useful temporarily. I told you about the three, the donepezil, rivastigmine, and your galantamine. Okay, those are the three that they use. So it does not reduce or reverse Alzheimer's. It is simply going to help them maintain that function that they have just a little bit longer. Okay, so cholinesterase inhibitors is basically preventing the breakdown of acetylcholine. Okay, because acetylcholine is the one that's going to signify or fire at the synapses in order to create that activity. So your cholinesterase inhibitors vary as far as the availability and the types of availability. So you have patches, of course, with your rivastigmine. So again, going back to putting it on the back somewhere so that that patient can't take it off, okay? Because we don't want them to miss those doses. So with their level of confusion sometimes, put them on the back so they can't reach them. And remember, rotate that site. Don't use the same site for 14 days once you rotate it. Now, donepezil is given once a day, and it's given in the evening time. Okay, so I'm going to suspect that it probably causes some type of drowsiness, and so I would give that at night so that they're going to sleep through that and they're not at risk for falls during the day. Okay, now the galantamine and the rivastigmine is twice daily with food. Now, if you are giving this medication in liquid form, make sure that you're mixing it with 3 to 4 ounces of a non-alcoholic drink. And you want to make sure that you're using an exact measuring apparatus. So whatever your medication came with, a syringe usually is what you're going to use. Okay, don't go to the kitchen, as we said before, and use your teaspoon or your tablespoon because it's not the same. Now, the cholinesterase inhibitors have been known to cause weight loss, so make sure that we're having our patients monitor their weight at least weekly, okay? And if they see a huge change in that, to report that. Now, when we talk about the transdermal patch for the rivastigmine, you want to make sure that you're putting it on an area that is not hairy. It doesn't have lotion on it, okay? That way it sticks well and they get the full absorption of that patch. Remember, when you're dealing with patches, put it somewhere that they can't remove it. But then when you replace it, make sure you're taking the old one off, okay? So make sure you're removing it when you put a new one on. So some of the expected side effects for our cholinesterase inhibitors, when you think about it, remember we're increasing acetylcholine, so it's considered a cholinergic agonist. And remember, acetylcholine works in the parasympathetic system, so we're going to increase that saliva, we're going to increase peristalsis, and then we're going to decrease our heart rate and respiration. Okay, so making sure that you're doing your drug reconciliations, because if they're taking another medication that maybe a beta blocker that decreases that heart rate, we want to make sure that we're checking that heart rate and those respirations, because we don't want their heart rate to be so low that we're in the toilet. Okay, so some of the side effects are going to be mild diarrhea, drowsiness, headache, loss of appetite, GI discomfort, and joint pain and muscle cramping. Well, all of those lead back to the parasympathetic system and what goes on within that system. Okay, so if you think about it, the acetylcholine in the parasympathetic system stimulates peristalsis. So that's where the mild diarrhea is coming from. So we're speeding up the process of peristalsis and how much time our food and stuff spends in there. We have meiosis, which is constricted pupils. So sometimes that can cause some issues with the visual field. So that can cause some headache, just that difference in transfer of, I guess, visual information from sight to brain, and can cause some headaches. So loss of appetite, okay, and then increased saliva. So there are some medications that you can take to decrease the saliva, but anyway. GI discomfort. If they're having GI discomfort, it's probably because we've increased that peristalsis, possibly, or if it's just the medication in itself making them nauseous or something, then again, ask them to take it with food. So adverse effects of cholinesterase inhibitors include hallucinations, dysrhythmias, possible GI bleeding, infection, and some difficulty urinating, or even some urinary incontinence. Okay, so I want to speak specifically about the dysrhythmias and explain that. This particular group of medications cannot be given with any other medication that prolongs a QT interval. So what is a QT interval? Some of you may know, some of you may not. So I'm going to explain it to you in the simplest of terms. The QT interval is just the length of time it takes for your heart to repolarize or recharge to create another heartbeat. Okay, so if you can imagine your heart's beating and it's beating and it's beating, but that QT interval gets longer and longer and longer, you have fewer and fewer heartbeats. So eventually, if it keeps prolonging, you're not going to have a heartbeat. Okay, so that's where we come into the fatal dysrhythmias. It's called torsades de pointe. Okay, it's a form of VTAC and it is lethal. Okay, so be especially mindful of any patient taking a cholesterol inhibitor, cholinesterase inhibitor, with any of the three medications specifically that I have listed on this slide. That's your dextromethorphan, your quinidine, and your fluconazole. Okay, now when you think about dextromethorphan and how often we may take that and not really even think about it because it's an over-the-counter for cough, should be safe. It's an over-the-counter, right? Well, in this case, it's not, because it does prolong that QT interval, and it can create that fatal dysrhythmia. So if you saw torsades de pointe, you would know that it is number one, a VTAC, and it is a fatal dysrhythmia. And then please be mindful of the three medications I gave you specifically that would be contraindicated in the case of taking a cholinesterase inhibitor. So some patient and family teaching with this particular group of medications is, first of all, they may not see improvement for a couple of weeks before they reach that therapeutic effect. So with the GI upset or the GI discomfort we talked about, you want to monitor for also GI bleeding that they're at risk for. So how do we watch for GI bleeds? Well, we're going to monitor for dark stools, okay, those tarry-like stools, and we're going to look for a decrease in hematocrit and hemoglobin. Well, by saying hematocrit and hemoglobin, that should automatically trigger you to think that this patient is going to need labs ever so often. Okay, so they're going to check some labs, but just know what labs to check for when you're looking at GI bleeds. Okay, now if they have breathing difficulties, they should seek immediate care. Okay, offer some bathroom training. If you have a patient who has some urinary incontinence, go check on that patient, take them to the restroom or bedside chair, whatever it takes, every 2 hours. Okay, work on that bladder training. Now, this medication can cause some dizziness and maybe some weakness. So you want to make sure that we're assessing our room for any type of hazards, something they might trip on, anything of that nature. Okay, so remind them to keep all follow-up appointments. Because we do want to monitor for that GI bleeding, okay, that could be. Now, when we do our labs, we're also going to do probably a bun and creatinine, okay. Now, remember, bun and creatinine will tell us that creatinine clearance is used for the metabolism of the drug. Are we clearing it the way it's supposed to, or is it just hanging out there because we're not metabolizing it appropriately? And so if it's just hanging out in there, then we might need to reduce the dose. Okay, so lab values are important with this particular medication. So make sure that you know some of the teaching that's on this particular slide, the urinary training and creatinine clearance. I told you what that signifies. Make sure you understand that. So our N-methyl D-aspartate receptors are the receptors that are in the brain that allow calcium into that area. Now, if there's too much calcium, then it can create these tangles in the brain that we're going to talk about. So this particular neuron receptor is related to memory and learning. So when those receptors are activated and too much calcium is entered, then we call those neuronal tangles, okay, in Alzheimer's disease. So the tangles are really just a little protein buildup. That's called TAU. T-A-U. So if you just picture brushing your hair or a child's hair and you have a tangle or a knot, so that's kind of what I relate it to typically. And so if you're brushing and we're not careful and we don't separate it appropriately, then we pull the entire knot out and it breaks off all the little strands that are involved. So the tangles in the brain are very much the same. So when we disrupt those neurons, then their transmissions are also disrupted. And then those neurons begin to die off. Okay, so if we rip that big tangle out of our hair, then we end up with dead ends. So this is where you start to see that decrease in cognition as far as memory and learning in your patient with Alzheimer's disease. So in this case, we use an NMDA receptor blocker, basically. So by doing so, we're blocking that excess calcium that's entering into the brain and causing those neuronal tangles, and then ultimately the death of those transmissions. Okay, so most patients will see an increase in their ability to think and process things when they begin this medication regimen. So we use memantine to treat this. Now, typically memantine, I'm sorry, I don't know why I struggle with saying that, but memantine is typically used as a combination treatment with a cholinesterase inhibitor. So if you remember when we just talked about a cholinesterase inhibitor, that's basically preventing the breakdown of acetylcholine so that we can better balance that acetylcholine dopamine, ratio and prevent those side effects from being so severe. So you may have a patient who's taking memantine and donepezil or one of the others, ristigmine combination treatment for these tangles. The expected side effects of memantine is headaches, dizziness, and constipation. And so if you kind of think about these in relation to your sympathetic and your parasympathetic systems, we're trying to balance the two. So until we get that dose just right, you may see some of these side effects, and they may still experience them even with a therapeutic dose for them, just because we are in that nervous system and we're trying to balance out the, that bronchoconstriction or vasoconstriction and dilation, and that peristalsis, too much or too little. So those are the side effects that you may see. As far as the adverse effects, this is going to be your hallucinations, your worsening confusion, depression, shortness of breath, incontinence, weight loss. This drug does cause weight loss or has a tendency to, and it can cause hypertension in some cases. So be mindful of those patients who may be taking antihypertensives or a medication that would help to increase that cardiac output. Their heart rate increases, their blood pressure increases. So look for those types of medications also. Now, if we know that weight loss is a side effect, then we want to make sure that we're weighing our patients probably weekly. I wouldn't say daily unless we're concerned about water gain as far as weight. But weigh them weekly to see if they're on track as far as their weight. All of those symptoms, the hallucinations, the worsening confusion, and depression leads you to believe that either this medication is not working at all and their situation is progressing, or they're just experiencing those adverse side effects that are more along the lines of that sympathetic nervous system. Okay, so all of those things are your expected side effects and your adverse effects. Some of the teaching with our patient and family with memantine is, of course, adherence to the dosing. We want to make sure they give it at the same time daily. We want to make sure that they do that because that helps to alleviate some of the side effects that may be caused by that high and low of those activity in the neurons, okay? So we want them to report any vision issues, skin rashes, shortness of breath, any type of agitation, confusion, dizziness, any type of incontinence or urinary issues, and weight loss. Okay, remember we're weighing them weekly. Now we just talked about the adverse effects of memantine, and it can cause hypertension. So remember, anytime you have a really high blood pressure, that's why we want them to report those vision changes, any type of issue with their vision, because hypertension can, in fact, cause some of those vision issues. So that's why we want them to report those. Now, we just talked about how some medications that can increase urine pH also affect the way this drug is excreted in the kidneys. So if you have a patient who has any suspicion of a UTI or anything like that, then that needs to be reported and a urinalysis should be gathered and tested. A lot of times your patients with a UTI, this is how they find out that they have a UTI, is you will notice some strange, acute, like it just happened today, mental status changes. And it's because of that UTI. And so they'll have frequency that they have to go to the restroom quite often. They'll have pain. And then, of course, with a UTI, they always have that odorous, smell. So we're reporting those symptoms because it's important that we don't allow an excess of that memantine to be circulating in there. Okay, so remember I said any increase in pH is going to cause this drug to not be metabolized correctly. Therefore, we have too much of this drug circulating in that patient. Okay, so your book talks about reporting some other signs of ataxia, and I don't know if you guys know what that is, but it's just imbalance and excuse me, an impaired balance or coordination, okay? And this can be caused by brain damage, okay? So we don't want our patients walking around with some type of brain damage going on. And remember, we are altering what's going on in the brain, so we have to think about those side effects of that. So that's what ataxia is. So we want them to immediately report that. Epilepsy. So epilepsy is a common type of seizure disorder. Now, this disorder relates to hyperexcitability of neurons in the brain, which continually trigger electrical signals or impulses that are then sent out to our muscles and other parts of our body. So that's where you start to see your patients in that convulsive state. So let's talk about epilepsy. So again, it's just a disorder where the nerve cell activity is disrupted, and there's tons of, I say, misfiring or just unnecessarily firing or sending signals causing seizures. Okay, so we're sending all of those unwanted electrical signals to our muscles. Now, all of those signals that are repeatedly being sent are causing that hyperexcitability of our central nervous system. So that's when you start to see your patients maybe fall on the floor and you start to see their body seize and convulse. And they have no control over their bodies at this point in time. Okay, so they may have contractions of their arms, their legs, maybe their facial muscles, so just various areas. And again, they have no control over this. So just because your patient has a seizure does not mean they have epilepsy as far as being diagnosed or that it may continue. So many times people can have a seizure that's brought on by something other than just a disorder, something else going on in the brain. So you can have a seizure if you have extremely high fevers, if you have a patient who's been in a motor vehicle accident and had some type of head trauma or even a fall. Extremely low blood sugars will also cause seizure activities. Remember, we need that glucose in the brain to function correctly. Alcohol withdrawal, that can also cause seizure activity. So a lot of times you'll see those people who are going through alcohol withdrawal, they're going to receive some type of anti-epileptic medication while they're going through that withdrawal process. Brain tumors, infection, of course, meningitis, and even poisoning can cause seizures. So when your patient has a seizure, you may see them lose consciousness, okay? And so with that, you may see some vision changes. They may not respond to your voice, okay? They may not be able to hear or to feel you touching them if you're trying to arouse them. And then patients have also said they have changes in taste and smell. So there's a couple of different types of seizures, and those are partial and generalized. Now, there are subtypes of each one, and if you look on page 170 on box 9.5, we can look at the different types of seizure activity. So, I will tell you up front that you need to know the types of seizures as far as it relates to partial versus generalized and what the subtypes are. You also need to know which type of seizure loses consciousness and which one does not. And if they do lose consciousness, how long is that time frame of unconsciousness? Okay. Now your patient can show or exhibit various seizure activity and symptoms of that seizure based on which area of the brain is affected by this hyperexcitability. Okay, so there's various different symptoms, and we'll talk about those. So let's look at the seizure classifications. So we have partial seizures, and then we have generalized seizures. So the first one you'll see in partial is going to be your simple seizures, and there's no loss of consciousness with this particular seizure. They're quick and sometimes not even noticeable. Your patient or your whoever is experiencing this partial seizure may just appear to be daydreaming. They kind of have that fixed gaze upon them. Now, typically, this type of seizure consists of slight changes in our senses and maybe, just like we snap out of it and just try to gather our bearings and our whereabouts. There may be some twitching of the toes, feet, fingers, and arms, lasting less than 60 seconds, so about 20 to 60 seconds. And I will tell you, you need to know the length of time on the seizures and how long they last, okay? Because I know they're going to test you on that. So the difference in a partial seizure and a complex seizure, which is the next one, simply involves the loss of consciousness. So in a complex seizure, we of course see that fixed gaze, and they're not responding to any type of stimulation. And so with a complex seizure, you're going to see some repetitive motions. It might be pedaling of their feet or moving of the head in a specific way, either yes or no, or something of that nature. Or they could just be sitting there with an emotionless blank stare. Okay, so the key to determining the difference is, again, that number one, loss of consciousness and the repetitive motions. So that's how you can differentiate the two. Now, the complex seizures will last about 45 seconds to 90 seconds. So it lasts a little bit longer than the simple seizure. So just know the difference between those. Now, partial with secondary generalization, I don't really think they're going to test you on that, but you need to know just the difference between simple and complex. So a partial with secondary generalization, it just starts as a partial seizure, and then they retain consciousness, and then they progress to a loss of consciousness. So just know the difference in the simple and the complex. So generalized, let's talk about those. So we have absent seizures, and those are sometimes called petit mal seizures. So we have grand mal and we have petit mal. So we'll talk about both of those. Now with absent seizures, they do have a loss of consciousness. It's typically less than about 30 seconds. And absent seizures actually affect both sides of the brain at the same time. Most of the time this is common in children. And then absent seizures rarely involve those motor movements. So you're not going to see those hands moving or those feet pedaling or anything like that. Okay. Now, on the opposite end of the spectrum, you have the grand mal seizures. These are your tonic-clonic seizures. So with the tonic-clonic seizures or the grand mal seizures, typically your patient will have some type of aura, kind of like when people suffer from migraines and they have that aura and they know that it's coming. And they may be even be able to say to you, I'm going to have a seizure. Okay, so it's not uncommon that they can let you know because they have that aura that precedes that seizure. So when your patient or anybody who suffers from a grand mal seizure, you're going to see those extreme bodily movements, just that whole convulsing of the body. Now, in the beginning, they're very rigid, and then they begin to have those compulsive movements or convulsive movements, and then they just lose their whole posture. Okay. Now, once they're over, we call this like a post-ictal state, and this is when they're sort of coming out of this whole seizure activity, and they may be confused and just kind of gathering their whereabouts. Now, on average, this tonic-clonic or a grand mal seizure lasts about 90 seconds. Now, another one we have is an atonic myoclonic seizure. Now, this one is a little different because what happens is basically they experience a myoclonic seizure followed by atonic. So, excuse me, with the myoclonic, you're going to have those jerky movements, and then you have atonia. So we just know that that's an absence of tone, okay? So another thing about the atonic myoclonic is this is sometimes called drop attacks because your patient may be, they might even be just standing and then suddenly they fall and then they're going to experience that seizure activity. So status epilepticus is a single seizure that lasts 15 to 30 minutes, or it can be a series of seizures in which your patient has a seizure, never regains consciousness, has another seizure, does not regain consciousness. So just in between those continual recurrent seizures, they're not regaining consciousness. So it can vary. It can be a myoclonic seizure. It could be a convulsive, just a varying type of activity. But now, if you're a status epilepticus, sometimes that's hard for me to say, this can actually be life-threatening, and it can even cause death. Okay, so if you think about it, these seizures are lasting up to 30 minutes, 15 to 30 minutes of continuous seizure activity or recurrent seizure activity with no consciousness regained. So you have to think about their, number one, oxygenation, and then how that can cause permanent brain damage and ultimately their death. Now, febrile seizures is just what it says. It is caused by typically high fevers. Mostly in children is where you're going to see the febrile seizures. And this is typically between 15 and 30 seconds as far as a time frame on how long that lasts. So those are your various seizure classifications. So the most important part is knowing the difference between which one loses consciousness and which ones do not, and some of the motions that set it aside or makes it different from the others, like your pedaling motions or those continuous motions. And then the duration, okay? So know those time frames. So we talked about our seizure classification. So now let's talk about how we're going to treat that particular diagnosis. So normally we have traditional anti-epileptic drugs. I simply just call them AEDs because it's easier. So with our traditional AEDs, those are going to be your phentoyins, your carbamazepine, your ethosuximide, there's valproic acid, and phenobarbital. So phentoians and the carbamazepine, they both work by increasing that seizure threshold, and they just basically bind to the sodium receptors on the nerves to make them less active. Okay, so think back to how we talked about the seizure threshold with some of the other medications earlier on, and that it lowered that seizure threshold. That was one of the side effects of particular medication. I don't really remember what it was, but when we increase the seizure threshold, then it takes a lot more excitation in order to create that, or a stronger excitation to create those seizures. Okay, so phentoians and carbamazepine slows the firing at the neurons. Okay, that's your carbamazepine. Now, they both work by altering those sodium levels. Now, when we move down to ethosuximide, they increase the seizure threshold by altering calcium levels. Okay, now when we talk about the AEDs and you're studying them, make sure that you know the difference in which medications alter what. So know which one alters your sodium and know which medication alters your calcium levels in the brain in order to increase that seizure threshold. Now, ethosuximide is most effective for absent seizures. Okay, so one thing that is also different with ethosuximide is that we can actually give this to mothers who are pregnant, okay, because it is the least likely to cause birth defects. Now, the others, we typically try to avoid them in pregnancy because it has shown to cause some type of birth defects. So we want to avoid those. So your ethosuximide is going to be mostly prescribed to patients who have those absent seizures or those petit mal seizures, okay? So continuing with those anti-epileptic drugs or our traditional AEDs, let's talk about phenobarbital. So phenobarbital is also a barbiturate. Of course, anytime you hear barbiturate, we need to think about CNS depression, okay? So phenobarbital works by raising that seizure threshold, and it works differently than the other two medications, the ethosuximide and the carbamazepine and phentoians. Those three work on calcium and sodium channels, whereas phenobarbital actually works in the GABA neurotransmitter receptors. Remember, we talked about GABA earlier on, and those GABA receptors, or that GABA neurotransmitter, is an inhibitory neurotransmitter. So it's going to kind of neutralize that transmission of all of those signals, okay? Now, I've already told you it causes CNS depression, so phenobarbital can cause some, of course, I guess, sleepiness, drowsiness, those types of CNS depressive symptoms. Now, phenobarbital has the longest duration of action, okay? It is used for many types of seizures. The only one that it is not used for is absence seizures, or those petit mal seizures, okay? Now, phenobarbital can also be used short-term for insomnia and anxiety. Again, it is a barbiturate, and they can use it for that. Now, I do recall when I was working in the NICU, they used phenobarbital on neonates who had cholestatic jaundice. And for whatever reason, I'm not sure what the action was or how it worked, but it always worked for that jaundice. So there's other uses for it, but in seizures, just remember that this one works in that different way as the others do, because it works in the neurotransmitter area, those neurotransmitter receptors. And it is not used for absence seizures, okay? And then we have, last but not least, valproic acid. So it also works by raising the seizure threshold, and it works on those GABA receptors, okay? So again, it works the same way phenobarbital does. It's decreasing those neural transmissions, therefore increasing the threshold, so it takes a stronger amount of excitation in order to cause a seizure. Okay, so valproic acid is also used in mental health to treat sometimes manic episodes and bipolar disorder. So there are other uses for many medications that we come into contact with, but just know that these two are particular in the in the way that they work at the GABA receptors. Okay, so they're different from the other traditional drugs, but just know that they work on the GABA receptors. The most common side effects with our anti-epileptic drugs are pretty straightforward. Phentoin is gum hyperplasia, which is simply just an overgrowth of that gum tissue. So we want to make sure that we're educating our patients about good oral hygiene. It can have some abdominal discomfort, and this particular medication, phentoins, out of all of the AEDs, it does not cause drowsiness. All of these others do. So it could have some advantages over some of the others just because it does not cause that drowsiness. Now, carbamazepine is straightforward. This is just your constipation, nausea, vomiting, and ataxia, which we talked about earlier in the chapter, is just those unsteady walking, that unsteady gait in our patients. This particular medication can cause some sun sensitivities, so we want to be mindful of making them aware of limiting time in their sun in the sun and wearing sunscreen when they are in the sun. Rash and muscle weakness. So ethosuximide is probably one of the least. Heartburn, nausea, vomiting, dizziness, drowsiness, and fatigue. Now, phenobarbital and primidone, you have to think about that because phenobarbital is a barbiturate, so you're going to see that CNS depressive signs. So decreased alert, maybe decreased heart rate, blood pressure, drowsiness. Again, you may see that ataxia with that hypotension, some blurred vision, dizziness, and those mental status changes. Okay, so that's all in that central nervous system. And that goes back to phenobarbital being a barbiturate. Now, valproic acid is drowsiness, muscle weakness, nausea, diarrhea, menstrual irregularities, anorexia, double vision, blurred vision. Okay, so valproic acid seems to have quite a few most common side effects. So just know what those are. Think about the medications, what's different about each of them. So phentoin is your gum hyperplasia. Carbamazepine is ataxia and sun sensitivities. Phenobarbital is going to be your CNS depression. Okay, look back at that CNS depression if you don't remember what those were. And as far as valproic acid, there's a lot of them. Just find something that works for you. I'm going to say double vision and blurred vision and those menstrual irregularities because they're different from all of the others. The adverse reactions of our AEDs are widespread. So phentoin is a known teratogen, so we avoid it completely in pregnancy for fear of birth defects. So phentoin and carbamazepine both affect bone marrow. So they're both going to decrease our white blood cells and our platelets. So we look at the increased risk of infection, and we also monitor increased risks of bleeding in our patients. Now, phentoin can cause bradycardia and some skin issues. So if you were to see on a test that your patient has described a rash on their body once they've started taking this phentoin, then they need to report that immediately to their physician because that can be signs of an issue with their skin that leads to a more severe case of Stevens-Johnson syndrome. Now, in Stevens-Johnson's, what happens is they may start with a small rash and then it starts to spread. This can actually even be inside the mucous membranes, your mouth, and things like that. And so basically that rash begins to turn into blisters, and it's very painful. So phentoin, again, known teratogen, and Stevens-Johnson syndrome. Carbamazepine, as I said, can cause anemia because it does affect the bone marrow. Again, it decreases white blood cells and platelets. So again, we're looking at that patient's increased risk of infection and an increased risk of bleeding. Now, carbamazepine can cause arrhythmias, tachycardia specifically, AFib, and severe hypertension. Now, phenobarbital, again, is that barbiturate. So we're going to see respiratory depression, and this medication should be avoided in patients with COPD. Why? Because it creates respiratory depression as an adverse reaction. And if our patients already have some type of compromised system, we don't want to further that depression in our COPD patients, okay? Now, phenobarbital, remember, is a barbiturate, so it is a controlled substance. So with that being controlled, then there is significant tendencies for dependency. All right, so phenobarbital can also cause bone marrow depression. It can cause cognitive impairments. Remember, we're going to see some of that sedation from the phenobarb because it is a barbiturate. Now, this one in particular can cause liver impairment, especially in long-term use. So think about children who might be receiving phenobarbital and how small that window is for them as far as liver impairments. Children less than 2 years run the risk of liver toxicity, okay, and bradycardia, even into coma. Remember, phenobarb is going to have that respiratory depression, so we have to be very careful when we give this medication. Now, valproic acid has been known to cause amnesia, arrhythmias, hearing loss, and GI bleeding. Now, these are your adverse reactions, so if your patient is suffering from any of those when taking any of these medications, they need to report them immediately so that that medication can be changed. Drug interactions for our traditional AEDs are widespread. So I would always encourage my patient to consult with a physician or pharmacist if they are in fact taking any of the following medications, especially if they're taking any of the following with our AEDs. So aspirin, of course, acetaminophen, and then warfarin. So any of those can create that prolonged bleeding. Now, when it comes to warfarin, you guys need to know which medication increases warfarin and which medication decreases warfarin and the effects of it. So carbamazepine reduces the effects of warfarin. Okay, so valproic acid increases warfarin. So you're going to think about those dose changes, okay, either increases or decreases depending on which medication they might be taking. Now, AEDs also interfere with oral contraceptives, okay? It reduces the effectiveness of oral contraceptives. And basically, it boils down to an isosome in the AEDs that accelerate the conversion of estrogen and progesterone, which are our oral contraceptives. And so therefore it decreases that efficacy of them. So if you have someone who is of childbearing age or anything like that, we need to make sure that they're either using a different form or a backup. Now, proton pump inhibitors and drugs for diabetes. So this boils down to the metabolism of those medications. So when you take a proton pump inhibitor, remember they're turning off that pump to decrease the gastric secretions in order to lower that acidic environment. So by doing that, if you're taking both medications, you're turning off the gastric pump. So there's not enough of an acidic environment maybe to melt those or to metabolize that medication. So It's just decreasing the metabolism of those. So those are some of the most common interactions with medications that patients take. So again, there are many, many drugs that AEDs interact with. So again, encourage your patient to consult with a pharmacist before, taking anything that they're unsure of with their AEDs. Teaching and nursing responsibilities when it comes to AEDs vary. So let's talk about the different medications and what those are. So with phentoin, we need to understand that there are different forms of phentoin and that they are not interchangeable. Drug concentrations vary depending on the type of prescribed. So warn your patients about gum hyperplasia and making sure that they have good oral hygiene if they're taking phentoin. Now, phentoin has mixed interactions on warfarin, so they're mixed as far as does it increase or decrease the efficacy or the action of that. So really, we just need to educate them on the monitoring of their anticoagulants and those lab results if they are in fact taking both of these at the same time. Now, this particular medication can be very irritating to the tissue. So we try not to give it IM, okay? Remember that. And phentoin is known to cause birth defects, so we do not use it during pregnancy. Teach them to take their pulse. Remember we talked about bradycardia and those other arrhythmias. So with phentoin, think about all of those. Try to give it in any other method except IM because it can cause severe irritation in the area where you give it. Now, carbamazepine, when we talk about this medication and our teaching points, we do not give this one in pregnancy either because it can cause birth defects. Again, teaching them to take that pulse daily because this too can also cause tachycardia, atrial fibrillation, and those other arrhythmias. Ataxia, we want them to, think about those uncontrolled movements and that unsteady movement, I guess I should say. So being mindful of risks of falls, okay, or their increased risk of falls. And again, think about carbamazepine. Remember, carbamazepine actually reduces the effect of warfarin. So you're going to see their doses increased if they're taking warfarin. They're going to increase the warfarin dose, not the carbamazepine. Now with ethosuximide, remember this is the one that we can use in pregnancy because it has the lowest risk of birth defects. So we can use that during pregnancy. So that's one of the advantages to that medication. As far as GI side effects, just ask them to take it with meals or a snack to decrease those problems. Now, phenobarbital, again, this is not given in pregnancy. It can cause birth defects. And remember, phenobarbital is our barbiturate. So again, teaching them about the CNS depression, that respiratory depression, and cognitive impairment, okay? And this can be profound, okay? So remember those adverse effects. So be mindful of telling them, what the CNS depression looks like, that decreased heart rate, decreased blood pressure, drowsiness, those types of things. And again, with phenobarbital, since it is a barbiturate, you want to make sure that warn their families and teach them about the increased risk for falls and how to prevent some of those. Remember maybe those non-skid socks or removing the rugs, and be cautious of pets. Now, valproic acid increases the action of warfarin. So you're going to see the dosage of warfarin decreased in this case. Now, valproic acid, especially with young children, remember we talked a little bit earlier about the toxicity of it with the liver. So we want our patients, especially the parents of children, to be monitoring that whites of the eyes and the skin for that yellowing color, that jaundice. Any darkening of the urine, we want that reported also. So notify them immediately. And then again, we do not use valproic acid for or anytime during pregnancy. So those are your teaching points and your responsibilities as the nurse caring for patients who are taking these particular medications. Okay, so when we're talking about teaching, make sure that you remember which ones you can take during pregnancy and which one you cannot, and what their effects are as far as warfarin. Does it increase or decrease? And then once you decide that, how are they going to change the dose of the warfarin that your patient is taking? Some newer AEDs that we're going to talk about, some have been approved for monotherapy, meaning that they can be used alone to treat patients who suffer from epilepsy, or they are used as an adjunctive therapy with traditional AEDs. So they might not be as effective, or they may increase the effects of the traditional AEDs. So there are 4 that are actually approved for monotherapy, and those are the 4 that we're going to talk about most in this chapter. So oxcarbazepine is a derivative of carbamazepine. You can see that carbazepine is very similar to carbamazepine. Anyway, they both work to block those sodium channels. However, oxcarbazepine has fewer side effects than the carbamazepine. That's a mouthful. Sorry. So oxcarbazepine, one of the most common side effects is visual. It affects our vision. So some blurred vision, double vision. Your patients may have some drowsiness, dizziness, headache, things of that nature, but that comes into play with the adverse effects, the hyponatremia. So because it does block the sodium channels, we may not have as much, circulating sodium in the system. So that's going to be your adverse effects. So amnesia is also another one. Now, anytime we talk about hyponatremia, we need to consider several things. Of course, muscles and our cardiac status. And I don't know if you guys really remember, but some of the symptoms of decreased sodium is going to be muscle weakness, headache, and a decreased deep tendon reflex. So if we were to check your reflexes, tap on the knee, you're going to see a decreased response in that if they're suffering from those adverse effects with that hyponatremia. Now, another thing we have to think about when we talk about hyponatremia and the lack of sodium is the use of diuretics. Okay, are we using a potassium or sodium wasting diuretic or a sodium sparing diuretic? Okay, so just be cautious with that. The rarest side effect of oxcarbazepine is bone marrow suppression. So with bone marrow suppression, you guys, we've talked about this several times, you see that decrease in white blood cells, therefore you have an increase of infection risk. So just remember those. Some of the drug interactions for oxcarbazepine is the same exact thing as carbamazepine. Now, there are a few added to this particular drug. So separate those that are different so that you can better pick them out on testing, let's say it that way. So all of the other drugs that carbamazepine interacts with, this one does also. However, this one has also listed antipsychotics and HIV drugs. So just a few more. Remember we talked about there is a plethora of drugs that our AEDs interact with. So we always have to weigh the risk and the benefits when we give any AED at all whatsoever. Okay, so sometimes you just have to roll a dice and take a chance that your patient won't suffer from any of those adverse reactions. So again, just weighing those risks and benefits, because from aspirin to acetaminophen and the huge list of drugs that it interacts with, your patient is most likely going to be taking a couple of those in addition to their AEDs. So just be mindful of oxcarbazepine. Some of the teachings, of course, is going to be lab work. Obviously, if hyponatremia is one of the adverse effects, they're going to start watching those sodium levels. Okay, so we want to report that if it's less than 135. Remember, that's 135 to 145. So anything less than that, we're going to report. Any type of extreme muscle weakness, continued infections, anything like that, we're going to report that because those are adverse effects of this medication. This medication also affects oral contraceptives just the same as our traditional AEDs. So again, you want to educate your patients on the use of a backup method, or maybe even changing the route that they deliver that altogether. If they're taking oral, maybe they can wear a patch if they have to take an AED. So those are your teaching points with oxcarbazepine. That one's pretty straightforward. We also know that folic acid is important because it helps maintain those red blood cells. Okay, so it's important that if you have a patient taking this, then they're going to have some lab work because we want to check that folic acid level to make sure that they don't become anemic. Okay, so the adverse effects are those life-threatening rashes, that Stevens-Johnson syndrome. Remember, we talked about the rash and that they need to report that immediately because then it becomes those blisters that spread. Okay. This is typically seen in children, the Stevens-Johnson syndrome, but there's also another one. It's called toxic epidermal necrolysis, and it is again typically seen in children. But 10 is what they call it. It's a severe skin reaction. And so with the 10, what you're going to see is a flu-like symptom. So if you were taking a test and we told you this child had flu-like symptoms taking lamotrigine, then you should trigger to think Stevens-Johnson syndrome or that 10, that toxic necrolysis. And basically what happens is the skin begins to just slough off and becomes extremely painful, leaving those raw areas on their skin. So always make sure you have them report any type of rash at all whatsoever when beginning this medication. Now again, your drug interactions are almost the exact same as the ones we've talked about previously. So the difference in this medication, which is an outlier, and the other medications is that this one actually interferes with TB. Okay, remember everybody probably had a TB test. So your lamotrigine is one that's going to interfere with your TB testing. Okay, so just be sure that when you're picking those outliers to remember for testing that you look for those things that are different. So every single one of those AEDs, whether new or old, interact with all of those other things except for your antipsychotics, your HIVs, and your TBs. So know which one of those are different, and that'll make it easier for you. And then again, your diabetes medications. So that's lamotrigine. Now, again, this one's blocking your sodium channel, so you want to look for those hyponatremia, those signs and symptoms of hyponatremia. Okay, educate them on folic acid supplements if they are lacking. Now, one particular thing I will tell you about this is if you have someone who is African American, then they're actually going to probably have a lower dosage of this medication because they tend to have a lower clearance rate. They're not clearing this medication appropriately. Don't know the rhyme or reason for it, but they often do need a lower dosage to prevent that overdose of symptoms. Continuing with lamotrigine, I just wanted to touch base with you because your book talks about your planning and implementation parts and your responsibilities. This particular medication comes with a starter kit. So the starter kit is based on whether this is a monotherapy or if it's given as an adjunctive therapy with an older AED. So depending on whatever monotherapy or adjunctive therapy your patient is taking will determine which starter kit is prescribed. So just know that there are starter kits and we need to use the appropriate one. Now, we as the nurse and them as the patient need to be extremely mindful of assessing that skin daily and charting that. And again, I can't stress the importance of remember assessing patients of other races because they do have a lower clearance rate. And remember, that's going to be your creatinine level to tell you how well they're excreting that medication. So these patients may have to come in for a creatinine level every now and then. So when we talk about this medication, one of the side effects was dry mouth. So sucking on hard candy or even chewing gum can sometimes facilitate more saliva. So also drinking more water, of course, but those are two of the big suggestions that we give to patients who are suffering from severe dry mouth. So if you see that on a test or on NCLEX, then you'll know that's going to be your answer. So that's lamotrigine. It's pretty straightforward because you've already discussed most of the side effects and adverse effects of the AEDs previously. These go by pretty quickly because they're all just about the same. So any questions on any of those, just let me know and we'll talk about them. Lacosamide is another Topiramate is the next one we'll talk about, and Topiramate works in 3 different ways. Topiramate basically prevents the spread of that excitability in those neurons. So it doesn't raise the seizure threshold, it just prevents that spread of the excitability. So the first way it works is at the sodium channels. It's going to block those sodium channels to stabilize that those neurons and that excessive firing. Secondly, it enhances the inhibitory neurotransmitter GABA. Remember, we talked about GABA being kind of a regulator. Okay, so we're enhancing that. So by enhancing the GABA receptors and the GABA neurotransmitter, then we can decrease that epinephrine, the norepinephrine, and the actions of acetylcholine. So we're blocking those excitatory receptors when we enhance those GABA neurotransmitters. Now, this particular medication is approved for a monotherapy, so it can be used alone, and it's typically used for partial seizures, tonic-clonics, and then the Lennox-Gastaut syndrome that we talked about earlier. This one has also been used to treat migraines, okay? So we'll just know what it does for a seizure activity. I'm not going to test you on migraines, but it has been used for that purpose. Some common side effects with topiramate is that abdominal pain, some nausea, dizziness, drowsiness, fatigue, changes in taste. That's different from some of the other AEDs, and your anorexia and your paresthesia. Paresthesia is simply just a sensation of numbness, of tingling, as if you're walking on pins and needles. Okay, so that's what paresthesia is. Now, your adverse side effects with topiramate is some memory impairment and electrolyte imbalances. Now, specifically phosphorus and calcium. So why is that important? Well, phosphorus, of course, and calcium helps in the formation of bones. Okay, calcium is important because that helps our muscles move. Now, phosphorus also helps with how the body uses carbohydrates, and it also helps our body make protein. So, extremely important imbalances there. At higher doses can cause elevated ammonia levels, which then leads to changes in consciousness, or I guess I should probably lean toward more toward confusion. High ammonia levels can cause severe confusion in patients. High ammonia levels also can lead to encephalopathy or brain damage ultimately, and then death. Okay, so it's extremely important that we're checking those ammonia levels. So some of the signs of an increased ammonia level is going to be unexplained vomiting, extreme lethargy. They're very lethargic. Temperatures that are extremely cold. So knowing all of that, we want to monitor some ammonia levels. We want to monitor our temperatures and our mental status. So are they alert oriented? Do they know where they are? Are they saying things that are just completely off the wall, unexplainable? Because ammonia levels will do that. So ammonia levels, usually 10 to 8, I think it's micrograms per deciliter. But I'm not going to test you necessarily on the level specifically. Sorry, but you do need to know that we're going to have some labs to monitor those ammonia levels. Now, lastly, topiramate is a known teratogen, so we are going to completely avoid it during pregnancy unless we just cannot control that seizure activity in any other way. Okay, now just as the same as all other AEDs, it can adversely cause some suicidal ideation and depression. Okay, so the biggest thing with Topiramate is those increased ammonia levels and those electrolyte imbalances. So remember those. Drug interactions with Topiramate are almost exactly the same as all of the other AEDs. This one is a little different. It does interfere with those cardiac drugs, so making sure that we're checking pulses, checking blood pressure. All of the rest are pretty much the same. Diuretics, diabetes, oral contraceptives. So the symptoms of multiple sclerosis can vary because it depends on what part of the brain and spinal cord that myelin has hardened in. So it can vary. Some common early symptoms of multiple sclerosis, if you look on page 179, I think it's box, it looks like 9.8, we can talk about some of those common early symptoms. So fatigue, double vision, blurry vision, muscle weakness, numbness of your arms and legs, difficulties walking, urinary tract infections, bowel and bladder dysfunction, depression, and difficulty concentrating. So our spinal cord innervates pretty much every part of our body. So that's why we can have all of those symptoms. Maybe not all of them together, but your patient's probably going to experience several of them when you start assessing them. MS is a progressive disease. They tend to have worsening symptoms as it progresses and fewer periods of remission. Okay, so multiple sclerosis cannot be reversed. Okay, and there is no cure. We can medicate it just like Parkinson's or anything else to alleviate some of the symptoms and slow the progression, but we cannot reverse any of that. Now, as we start to talk about some of the things that we use for multiple sclerosis, I want you to pay especially close attention to middle of the page on 179 when we're talking about multiple sclerosis. It talks about management of MS and that every single first dose of these drug regimens are started with a specialist. So if you see on a test anything about MS in the beginning of treatment, then you're going to know that your patient is in a clinic somewhere with a specialist before they ever start this regimen. As this disease progresses, you'll start to see these patients decline in such a way that they end up in assisted living or long-term care facilities because they can no longer take care of themselves, and it's very trying and tiresome when you think about a total care patient and how that can affect families, especially if they lack a support system. So let's talk about some of the drugs that we use in multiple sclerosis. So these again are going to be non-specific anti-inflammatories. This is your corticosteroids again, and remember that's just decreasing some inflammation. We have some biological response modifiers. Again, those just reduce an immune response. And then we have monoclonal antibodies. They destroy lymphocytes that are involved in the process of multiple sclerosis and the disease process. And then there are some others that are just grouped in neurological drugs. So the neurologic drugs basically protect that myelin sheath, therefore giving some improvement in the transmission of those neurons and the firing. So we'll talk about all of those. So one of the first line of defenses for MS, or one of the first treatment options, is a non-specific anti-inflammatory drug, which is our corticosteroids. Now, if you don't remember everything about corticosteroids, go back and look at chapter 12 and some of your notes. But just remember some important things about corticosteroids in that it can increase our blood sugar, and we need to teach them to check it more often, and also increases their risk for infection. So those two things are important when we're talking about corticosteroids. So we've talked about corticosteroids so much. I feel like you guys are pretty comfortable with them now, but those are two important things that we need to be mindful of. So if you have questions about corticosteroids, again, look back at chapter 12 or send me an email and we'll talk about it a little bit more in detail. But those are one classifications that can be used for MS. Biological response modifiers are given for MS, and the way this works in the body is they're given to reduce that patient's immune response to triggers that cause inflammation and that immune response. And there's a couple of different methods to deliver this particular medication. So you have beta interferons, fingolimod, glatramine, glatramine, and then the teriflunomide. Yeah, that's a mouthful. Just know that they're biological response modifiers, okay? And remember, with MS and these medications, any medication that is given is always given by a specialist. So side effects or expected side effects for biological response modifiers are flu-like symptoms. So we're going to take temperatures and check vital signs. Headache, pain at the injection site, or some type of reaction localized. Peripheral neuropathy, that's just kind of that tingling numbness in your hands and feet. Elevated liver enzymes and slowed heart rate can be some of the side effects of this particular group of medications. Now remember, these patients are in a facility being monitored by a specialist, okay? So just know that these are used to reduce the immune response in patients, okay? So monoclonal antibodies are given to slow that progression. They're inactivating lymphocytes that destroy that myelin sheath that protects those neurons. Okay, so all of these are given IV. They're either scheduled monthly, every 6 weeks, or maybe once a year. So this is going to be your drugs that end in AB. Okay, this is going to be, I'm not even going to attempt to say the names. So if you want to look at the names, they're on page 180. I'm in the middle of the page. Just know that monoclonal antibodies are given in specialized centers. They're given on a certain schedule. And one of the biggest side effects or risks with monoclonal antibodies is the fact that this is one of the higher risk categories for severe allergic reactions. So with that being said, if you know going in and you're the nurse in that center, that specialized center, that this particular medication can cause some extreme severe allergic reactions, what is one of the things that you want to have right at the bedside? Me personally, I want my crash cart and I want some oxygen and maybe some epi. Okay, I want my EpiPen close by. So just think of those types of things. Don't worry so much about the names of these drugs because I don't think any of them are actually on the test as far as specific names. They're just listed as monoclonal antibodies, okay? Again, our lymphocytes are being reduced, so remember lymphocytes are going to entail that lowered white blood cell count, so we're at a higher risk for infection. Okay, so If you want to review some of the others, increased risk, as I said, for severe allergic reactions. Flu-like symptoms could be the side effects, some back pain, hypotension, edema, and your patient should never be taking more than one monoclonal antibody medication at any given time. Okay, so don't double dose them. One neurologic drug for MS is dalfampridine. Okay, dalfampridine is the one neurologic drug used. So this medication is going to protect those nerves in that myelin sheath from destruction, therefore improving those impulse transmission. Now, the side effects are on page 180 again, and there's quite a few, but one of the most important adverse effects of this particular medication is that it can cause a decreased seizure threshold. Now, we just talked about all of that with seizure activity. So remember, anytime you decrease that seizure threshold, you're going to increase that possibility of seizure activity. So with this one, you have an increased risk for infection, headache, dizziness, GI issues, constipation, nausea, flushing, itching, rashes, all of that. But the one extremely important one is that it can cause confusion and seizure activity. And as I said, the way it does that is by lowering that threshold, that seizure threshold. So as long as we keep that threshold lowered, you're going to see your patient with an increase in seizure activity most likely. So that is the last drug in this particular unit. So if you will have any questions about any of it all whatsoever, please send an email to let me know.